Greetings to you all in our October Endocrine Grand Run for the year 2021. We will be speaking in both English and Arabic language for predominantly Arabic followers. In this round, we will be having a run. Initially, we start with a run through the embryology and histopathology of the pituitary gland. This will help us laying the foundation of understanding how the pituitary pathology impacts the variably impacts the pituitary function. From there, we will present cases related to Rathke's cleft cyst remnants, and we'll discuss primarily the presentation and how they present, how the disease progression, and of course how we the management choices that we have in our armamentarium. And finally, in the last section of this presentation, we'll be looking at the cases of pituitary metastases, how they presented and how we managed. With regards to pituitary embryology, as we all know, this is a solely ectoderm gland formed by fusion of the a pouch that grows inward from the roof of the mouth, and another pouch grows outward from the base of the, later on will be cerebrum. These two pouches get close to each other, they fuse with each other, and they form the pituitary gland. The fusions of these two ectoderms will end up forming four different parts or sides or parts of the pituitary gland. The pars distalis and the pars intermedia, they both will compose in the future development the adenohypophysis. The pars luposa will be known as the neurohypophysis. And this, of course, the pars tuberalis, where there's a lot of melatonin receptors, and that's why we think it's has a role in the photoperiodic regulation and the circadian rhythm in humans. The pars intermedia will host the periopo melanocortin cells, and it's probably due to its location here, it's less likely to be damaged when you have a growing macroadenomas in the adenohypophysis. So it's more or less a protective site for these cells, which are critical for our existence. The neurohypophysis, as we all know, is a continuum with the neuronal cells from in particular the supraoptic cell here and the paraventricular cells. These axons will land and eventuate in the neurohypophysis, which is a non-secretory part of the adrenal gland. The pars distalis, or the adenohypophysis, will have two types of histopathological cells or groups. The group that doesn't take any stain, chromophobes, and groups that stains well, the chromophils, either to acid stains, to hexy stains, or basophil stains, so the alpha and beta respectively. The hematoxylin stain or the basophil stain basically will stain all the cortical troph, thyrotroph, and gonadotrophs, while the acid stain will be taken up by somatotroph and lactotrophs. Chromophobe, as you could see here, doesn't take any of these stains. They remain gray. There's an old slide that showed the acidophil, basophil, and the chromophobe here. This staining is old, it's not adequate, and we came up in the last 20 years or even more with immunohistostaining, where we use antibodies against certain each cells individually, and this is a far more precise and accurate, and we do tend to wait for the immunohistostaining before we sign on the diagnosis after surgery, and we cannot rely on the old staining system. Another slide, and I thought I will, it's worthwhile running through, is the portal system, and by definition, portals venous system is as opposed to normal venous, conventional venous system. By definition, the portal system connects two arterial systems. That's exactly, you have that for the liver, and you have it in the pituitary gland. Now, because they are veins, they have very low pressure, and they can compress very quickly at a smaller pressure. If the portal connection system was arteriolar in nature, then you would need a much higher pressure to compromise the pituitary vasculature. So that's a quick run through, and I thought also worthwhile mentioning that the neurohypophysis is a continuum, again, with the optic chiasm and the median eminence, of course. So if you have septo-optic dysplasia, when the child when the pituitary gland fails to develop, the child or the newly born baby will have lots of frequent severe hypoglycemia when the mother doesn't have any history of gestational diabetes. And unfortunately, the clinician need to tell the parents that this child will be blind as well. So this is how the anatomy is highly integrated in the small part of the brain. Now we'll move on from there to our first case to discuss our 58-year-old Vietnamese healthy or previously healthy young man who wasn't on any regular medication, not on any regular health products, and I do incorporate, and I encourage you to incorporate this question in your history taking. Always ask the patient if they are taking health products. A lot of these health products have substances such as biotin that interfere with our endocrine tests. Now, this guy presented to the emergency department with acute onset of nausea, vomiting, and abdominal pain. He did reported to the A&E physician that he was feeling rather unwell over the last few months. He was slightly hypotensive, pulse rate is on the high side, his sodium was low, his potassium was marginally elevated, he had normal kidney function, normal pancreatic lipase and amylase, and normal inflammatory markers. However, his cortisol, which was requested by the A&E physician, came back fairly low, and there was incipient adrenal crisis, and he was started on salvage dose of hydrocortisone parenterally while waiting for the endocrine input. And what we did is, obviously, we asked for a whole pituitary panel, which clearly showed that the TSH was inappropriately low for a low T4. He did have central hypogonadism with a low LH, well, low normal LH, and a fairly low testosterone. His prolactin was marginally elevated, and his IGF-1 is again low. So we started him on proper hormone replacement therapy, and we requested MRI, which showed this pituitary lesion, which was iso-intestinal to a gray matter on T1, with however, with the contrast, gadolinium contrast enhancement. I hope you appreciate what we call it the claw sign, which represent essentially a squashed pituitary tissue, which was pushed downward and posteriorly by this mass. And on T2 images, this mass actually takes up, it lights up, it's actually hyper intense to the gray matter in a clear representation of protein. And there was a dot sign, and also a hyper intense small area within the this mass. So this is clearly a case of a pituitary cyst, and it's more likely than not to be with the dot sign and the close signs, and the overall clinical picture to represent Rathke's cyst. The patient developed bilateral quadrantenopia, and he underwent decompression of the cyst, and he remained permanently panhypopid after. So from this case, we'll move to discuss the Rathke's cyst, and it's a fairly common incidental finding, usually of the pituitary gland, and it represents about 1 in 10 of the symptomatic cellular lesion in some studies, and half of these cases tend to have a supracellular extension. But to have a merely supracellular cyst with normal pituitary cellular and no intracellular representation of the cyst is very rare. And if that would be the case, then this is more likely to be craniopharyngioma, which can present as a pure supracellular lesion. So that can help you in the differential between Rathke's and craniopharyngiomas. The T signaling of the cyst is variable from hypointense to isointensity in T1, but usually they don't usually be hyperintense on T1 unless there is a bleed into or hemorrhage into the cyst where you have fluid level. So, but in T2 they usually either iso or hyperintense, and that's because they have high protein content. So it's nevertheless not difficult to have a provisional diagnosis just by looking at these images at a glance. And please do note that there is, once you give the gadolinium, the rim of the cyst will light up, and that's usually represent pituitary cells being squashed around the margins of the cyst. And it's there in about 70% of the cases. Now, the size of the cyst, as I mentioned, can vary a lot from small to mid to large cyst here. And again, I hope you appreciate with the gadolinium enhancement here, you see the margin of the cyst hyperintensity, and here as well on the sides here. So that's all represents pituitary tissue around the wall of the cyst, as you would expect. Now, the dot sign, which is thought to be pathognomonic for the cyst, it just represents debris within the fluid. So these debris will collate and congregate, and they are hypointense, and that's why actually on progress MRI you can see it floating from one end to the other, depends on the position, head position of the patient. So that's a quite helpful thing to find in the diagnosis. So again, in the T2 images, the cyst either slightly or mildly hyperintense because of the protein content. And these are different other examples, and I hope you appreciate it. I think this slide I just wanted to highlight on gadolinium enhancement, the rim lights up related to pituitary cells, and the various signals, usually iso or hypointense, but they can be hyperintense on T1. Rathke's cyst is often asymptomatic incidental finding. Larger cysts can present, and this is a study done here in Melbourne that showed that actually between 5% to 30% of the cysts in these meta-analysis, actually they can grow in size. They rarely bleed or rupture, but they do still, and as I mentioned, they can progress in size, and this is why we do interval imaging for the cyst. Treatment option. The mainstay treatment is surgical decompression with marsupialization, if possible, to prevent recurrence. We don't do total resection anymore because of the risk of the high risk of permanent DI. And it's easy to be done with quite a significant success rate in terms of the recurrence rate is up to 20%, and that's getting lower and lower with more advances in our techniques. It's usually done transsphenoidal surgery, where the surgeon basically aspirate and marsupialize, if you can, the cyst and graft the surgery. Now, I know in the past some surgeons or some schools of thoughts they recommend drilling holes in the base of the cellar to drain any recurrence fluid, but that will be as a trade-off for the increased risk of CSF rhinorrhea. So few neurosurgeons prefer not to. In case of large cysts, I mean, they can still do it even in the supracellular cyst. By that I mean the transsphenoidal approach. Well, I can, in really nasty large one, they can go transcranially and fenestrate the cyst to the CSF, and that will be enough at least. So that's one approach here, or the standard approach. And this is a study that showed the improvement of symptoms. I'm sorry, my photo is actually blocking this study here. And essentially, in this more popular meta-analysis showed up to 94% improvement in endocrine. This is primarily driven by improvement on prolactin levels on this meta-analysis. And we will, I think from this meta-analysis, I will have to take you through the indications for surgery in Radke's cyst. There are indications that have the consensus and others are contentious. We'll start with the consensus indications, and essentially an increase, by that I mean increase in the size of the cyst structure, and visual field loss of any degree. All these merits surgical decompression. Now, headache is not. 90% of the population, I think if you ask them, they will tell you we have a headache every now and then. And if you're going to operate for this reason, you're more likely to have unresolved symptoms. So we don't take the patient to theater just because of headache when the cyst is of moderate size and it's been stable. Okay, you probably need to think of migraine or another reason, or try at least treatment for migraine before. And I haven't, in my experience, I haven't referred any patient with Radke's cyst for decompression surgery because of headache alone. They need to have one of these other indications. Now, regarding the change in size, or the possibility of the cyst to increase in size, I tend to do interval imaging for up to 2 or even 5 years. So I do it yearly when diagnosed for 2 years, and after that I'll see the patient on year 5. This is my general approach, and before I discharge the patient from my care, I'll tell him or her, look, if you had unusually severe headache, you become lethargic, tired, symptoms suggestive of hypocortisolism or hypothyroidism, and of course, if you had any visual field defect and you start to trip over the furniture when you walk, يعثر المريض من يمشي بالأثاث على جانبه, indicative of heminopias. So in these cases, I need you to go back and do a thorough assessment of your Radke's cyst again. And if the patient is properly educated, then yes, after 5 years, you could discharge him, and there is no need for a long life follow-up. We'll move on to the contentious indications. These indications, by definition, they are debatable. We don't universally agree on it. متفقين عليها كلنا. عموما الموضوع يخص إذا كان عندك stable size Radke's cyst where there is hormonal deficiency or hormonal hypersecretions. What are you going to do about it? Now, if there is hypothyroidism or central hypothyroidism, or if the Rathke has caused hypocortisolism, then you could ممكن واحد يفكر بالسيرجري، خاصة إذا كان مريض of new onset duration. مثل ما شفنا بمريضنا there was no response لأنه it took few months before diagnosis. So it's very unlikely for these cells to recover إذا صار لهم فترة طويلة damaged. Hypogonadism, when it's presented, it's usually too late. And what do we treat? Just give them testosterone, for example, or HRT or MHT for females. So hypogonadism, it's never been in my experience, I've never seen it as a reason for a surgical referral. So that's one category. الكاتيجوري الثانية اللي هي hyperprolactinemia, which is not uncommon finding with Rathke's, possibly related to stock effect. However, this is not an indication for surgery, and we tend to treat with cabergoline. إذا كان المريض, older female, you might not need to treat it at all. Female with mild hyperprolactinemia and still having regular periods, you don't need to offer treatment. Just keep an eye on it. Men with hypogonadism, you can treat with cabergoline, see what happened to their testosterone. You might even consider giving testosterone supplement. ممكن تعطي testosterone supplement لهؤلاء المرضى من غير ما تاخذهم to surgery. أو إذا كان testosterone normal with mild high prolactin, then leave it be. Don't worry about it. There is always the possibility in the differential diagnosis of cystic prolactinoma, but this is a whole different topic, and they usually tend to be very aggressive and they're not stable in size in R3. So, and the prolactin will be quite high, not just mildly elevated. So generally speaking, mild hyperprolactinemia with Rathke's cyst, we tend to treat with cabergoline if indicated. In an asymptomatic and biochemically eogonad, male or female, then we could leave it. Or either way, you can treat it for 2 years and see what happened to their prolactin levels. But generally speaking, this is not an indication for surgery, and I suggest that you revisit the diagnosis. In cystic prolactinoma, هذا الحقيقة موضوع. It's very unusual to miss out on the diagnosis of cystic prolactinomas. Okay. So the other modality of treatment we have is radiotherapy. So we talked about surgical treatment and hormonal treatment for Rathke's cyst, and now the last new kids around the block. This is a study from 2020, a year-old, a small number of patients. They followed them up for a median of 69 months, up to 150 months actually, and they all had at least 3 surgeries because they had multiple recurrences of Rathke's cyst, multiple, مو بس واحد, أكثر من at least 3 on the median. Some of them actually had 5 recurrences, and essentially they treated them with stereotactic radiosurgery with a fairly good success rate in terms of stabilizing the cyst. The whole idea of the radiosurgery was to prevent the cyst from growing bigger again. So yes, there is a room for radiosurgery, and I think in the study that I believe they used both linear stereotactic beam and or photon beams as well, in average 25 sessions or so. So there is a room for stereotactic surgery in multiple recurrences of the Rathke's cyst, مو recurrence واحد. All right, from there we'll move to case vignette 2, when a 33-year-old female, she presented for, she was planning family, she presented with a secondary infertility due to hyperprolactinemia. She has had unassisted pregnancy with her first child. Her prolactin was mildly elevated, and the MRI pituitary showed macroadenoma. Now, I hope you appreciate on the T1 images, again, this iso intensity to the gray matter. There was a patch here of hyperintensity, and once you give the gadolinium, the rim of the lesion light up and become hyperintense, and all it's consistent with Rathke's. However, And of course, in the T2 images, you could still see the cyst was homogeneous. So, except this patch here. However, the initial diagnosis was pituitary macroadenoma with possible hemorrhage. Now, it's very unusual for the macroadenoma to light up, to have a hyperactive rim. And of course, they tend to be heterogeneous, and this is what confused us. حقيقة هذا اللي خلانا نأخر التشخيص. We thought, okay, more likely with this apoplexy. Now, in hindsight, it's very unusual to have pituitary apoplexy without deviation of the stalk. Okay, so that's another important thing, that point that could help you to favoring Rathke's cyst. So the patient declined surgery initially. We wanted to take her to surgery, and we decided, okay, well, she looks well. She doesn't have any, suggestion or any suggestion of panhypopituitary hair. Apart from mild prolactin, elevated prolactin, the rest were quite essential. Pituitary panel was normal, and we decided to follow her up in 6 weeks' time. And the differential diagnosis we were favoring up until that point is a non-functioning adenoma with apoplexy. And we thought, as time goes by, as you see with apoplexy, the adenoma will regress, more likely than not. And so we started on cabergoline just to treat the mild hyperprolactinemia, and aiming at re-establishing menses. And at some staging point, we, after she gets pregnant, we could consider surgery, decompression surgery, or debulking surgery, sorry. And in 6 weeks' time, obviously, with a close follow-up, you don't leave that kind of patient with macroadenoma and apoplexy, at least as it's provisional diagnosis of macroadenoma and apoplexy. You don't leave them for too long. They need to have a close pituitary hormone follow-up. And we had an emergency lab call. The pathologists need to call you. They need to have your contact number for emergency call, and have the patient with these results. This is genuinely low numbers, and so she underwent an emergency MRI, and we saw the stalk has become very thick, which wasn't the case before, and slightly increasing the size of the adenoma. She underwent transsphenoidal emergency surgery and started on HRT peri-op, of course. And the histopathology came back with necrotic fragments, and I'll take you through. This is when you marry the histopathology with your radiological findings. So this is the cyst wall, and if you give it growth hormone, it stains. If you give it corticotroph hormone, it will stain, because this the pituitary tissue being squashed against the wall of the cyst, and that's why it light up on gadolinium scanning. There was a lot of plasma cell and a lot of lympho T cells, and primarily IgG4. So the question is, was that an IgG4 hypophysitis? Now, post-surgery, this is the MRI, so almost complete regression of the cyst. The stalk was still there, came back to midline. It's no longer as thick as it was, and she was on multiple hormone replacement therapies, as you would expect. Now, whether this was a secondary hypophysitis, and you look up the diagnostic IgG4 hypophysitis, and you look up the diagnostic criteria, you need at least 20%, and really she scored only 14 based on the IgG4 staining. Now, her connective tissue screening was normal, vasculitic screen was normal, she had axial images of her whole body, all came back normal. So there was nothing indicative of IgG4 hypophysitis except the IgG4 cells. This is one of the criteria, but not all of it really. Please لا تذكرون المحاضرة السابقة With regards to IgG4 hypophysitis, the key issue in the diagnosis was the storiform fibrosis and the obliterative phlebitis, which wasn't the case here. And although it can be patchy and you can have false normal tissue or skip lesions, but when you took the whole cyst wall out, then you really can't miss out on any fibrotic spots. So I'll take you through what's with and against each of these diagnoses. With any type of hypophysitis, you will find there's a really very high intensity with gadolinium, which wasn't the case in our patient. And yes, she did have some nocturia at some stage, but that's because she had inflammation of the stalk after the cyst was ruptured. The heterogeneity with regard to non-functioning macroadenoma, they tend to be very heterogeneous, like this picture here, this patchy area of iso, hyper, or hypo intensity, and they shouldn't be much of rim enhancement. And of course, with the Rathke cyst, you will have this homogeneous, proteinaceous bright spot on T2. So the diagnosis has changed after this event into ruptured Rathke cyst, which is not uncommon. It's well described, and it can present same as apoplexy with severe headache and visual disturbances, and more common in females. And in MRI, you would still find that the stalk in the midline, unlike the apoplexy, where the stalk tend to be pushed aside. And you could have all sort of inflammatory cells, even xanthomatous or multinucleated. So this is another case in the literature. This is not our patient here, but it clearly showed another case of ruptured Rathke cyst with a lot of T cells and B cells in the aspirated tissue. Now, how about IgG4 hypophysitis? Can it cause? Can it be present as a cyst? There was a case series of 7 patients in this study, which one of them, case 2, had a cystic formation, which was fairly small. So could that be a necrotizing cyst formation? Possibly. We'll never be able to know, but it's no way as dramatic in terms of size and homogeneity as our patient. And at the end of the day, Rathke cyst is far more common than IgG4 hypophysitis anyway. So that was the case of ruptured Rathke cyst with subsequent inflammation of the stalk, and the patient developed DI and panhypopit. And she remained panhypopit even after a short presentation to surgery. So that will be the case here. And we'll move on to the second section of the presentation of pituitary metastasis. We'll start with this case vignette of a 71-year-old gentleman referred to the practice with deranged TFTs, and I hope you appreciate low T4 and inappropriately normal TSH. So that was enough for us to signal central hypothyroidism. The patient has a 2 years progressive history of fatigue, generally unwell, mild polyuria, and he had the past history of renal cell cancer that was resected 17 years ago with multiple stabilized pulmonary mets after he had his chemoradiotherapy. And he was still under active surveillance with the oncology unit. So this is his pituitary panel, which clearly showed still normal level of cortisol with good short synaptic stimulation. And he was hypogonad as well as central hypothyroidism. This is his pituitary MRI that shows heterogeneous macroadenoma abutting the chiasm. And of course, the first thing comes to our mind whether this is a non-functioning macroadenoma. He was found later on to have hyponatremia, and short synaptin dropped down as we progressed within a very short period of time. He was started on HRT appropriately, including cortisol. and the concern was at that point, within 1 month period of time, he lost his corticotroph despite hardly any changes in the size of a tumor. So that was quite alarming finding. بمعنى إنه without any change in size in the tumor, he lost his corticotroph, and that would have been indicative of macrometastasis. Progress on MRI from January to June showed some degree of increase in size. He underwent, because we were not sure, I mean, the gentleman had renal cell carcinoma, but they are not known to cause pituitary metastasis. Usually it's lung cancer in male and lung or breast cancer in females, but not renal cell cancer. So we had to take him to surgery for diagnostic procedure, and as you would expect with metastases, they tend to bleed fairly vigorously. He lost more than half a liter during that surgery. It was very bloody field, and the histopathology came back consistent with renal cell carcinoma metastasis. And of course, the histopathologist has to stain special stains for renal cells after you give them the history. So that was the case, and the oncology team started him on sunitinib with palliative radiotherapy, and he's still alive as we speak. So this is the reason for the delay in the diagnosis is the fact that there's only 41 cases of renal cell cancer with pituitary mets reported in the literature, and so that actually put a break on in our thoughts initially. I'll move from there to another case, synopsis of case with a 68-year-old female who had a progressive headache, and initially had CT scan that showed intracellular lesion with heterogeneity there. You can see a bit of spots, dark spots here. And of course, from there we went to the MRI that show ISO intensity to T1 and bit of hyperintensity here. Once you give the gadolinium, you see more heterogeneity there with some flow voids, I would have thought. So the pituitary panel consistent with central or pan-hypopit, low cortisol and ACTH, low LH and testosterone, low T4, and low normal TSH, and all in keeping with pan-hypopit. And she did mention to us that actually she did have an episode of polyuria polydipsia consistent with DI 6 months ago. So central hypogonadism, hypothyroidism, hypocortisolism, and stalk effect related to the mild increase in prolactin. She did have a surgery to remove the mets. A frozen section showed tumoral cell right in the front, immediately showed tumoral cells, and the histopathology cancerous cell that was actually ER positive. And obviously she did underwent generous debulking surgery, and the breast mammogram showed a 1.2 cm lesion, proven to be later on breast cancer. She was started on HRT appropriately, and once she started on hydrocortisone or hydrocortisone, she developed DI, as you would imagine, because of the hydrocortisone unmasked vasopressin deficiency. So she opted against mastectomy. She opted palliative therapy, and she underwent another debulking surgery for severe incapacitating headache, and she passed away the same year. We'll move on to another case of 69-year-old lady with deteriorating functional status and severe headache, and she was hypotensive on examination with normal visual field, and that was her MRI again, very on gadolinium scanning, and on T1 you see grossly heterogeneous, more than ugly pituitary gland that encasing both cavernous sinuses. And there was whatever you like to call it, snowman sign here, which represent rapid growth of the cancerous cells, and you still can find this in adenoma, by the way. This is in no way pathognomonic for cancer, when the adenoma grows very quickly through the diaphragmal cilia before it gives chance for the cilia to adapt and accommodate. So the panel again came back with hypogonadism, with low LH and low E2, and IGF-1 was low, cortisol was very low, and she was starting hormone replacement therapy. Again, as you would expect, once you give the hydrocortisol, they develop the eye if they haven't had the eye initially. And her visual field loss was, well, she developed visual field loss very quickly afterward, as you would expect with rapidly growing tumor. So from there, I'll take you to the issue of interest, pituitary metastasis. They do present with headache. It's unusual for them not to present with headache. And the headache, I mean, we all, احنا كنا يصير عندنا headache every now and then, ولكن it's just very distinctive. They tend to be incapacitating, severe. The patient hasn't experienced this headache before. Many of them, but not all of them, most of them will have the eye. And if they haven't had the eye on initial presentation, once you give them hydrocortisone, مثل ما شفنا مع الكيسات هذه, they develop the eye down the track for surgery. So even if you were not sure of the diagnosis for surgery, once they develop the eye, you start thinking there was something funny going on. It's very unusual for pituitary macroadenoma, non-functioning macro or functioning macroadenoma, benign adenomas, to cause the eye unless there is an inflammation of the adenoma, apoplexy, or rupture of a cyst. They can develop the eye because they will have inflammation of the stalk. The stalk will get irritated by the content material of the cyst or the blood apoplexy إلى آخره. Now, مثل ما شفنا بهذه الحالة المريض in the previous case, the patient lost the corticotrope without significant change in size, and that's because of the macrometastasis. This is essential. We have to bear in mind even when you have macroadenoma, you don't assume this is enough to cause low cortisol or loss of the corticotrope. So remember, تذكرون احنا تكلمنا بالامبريولوجي شوفوا قلنا كيف ال ACTH is protected in the pars intermedia. So you really need to have a very good reason to lose these cells, and usually, well, not usually, if it is more likely than not, it would be macrometastasis. Okay, مو لأنه هي macroadenoma وخلاص. So that's an indication of a clinical indication for the endocrinologist and the radiologist that this is cancerous cell rather than non-functioning macroadenoma. Please bear that in mind. Diagnosis need to be done before surgery if you can. Then the surgery can be very complicated and hemorrhagic. So I guess that's what I want to say in the slide. Now, with regard to the radiological predictors of cancer, you will have normal cilia because it's a rapidly growing cancer. متى الصلة يصير بها deformities, dural enhancement مثل ما صار عندنا بالكيس السابقة, bony destruction which can be picked up by CT scan better than MRI. مرة أخرى CT scan is better than MRI in picking up bony destruction. So مو يجيك المريض إنه عنده MRI you stop. So if you're concerned with macroadenoma, you do have to do CT scan as well routinely. Stalk enhancement and thickening, of course, in majority of cases. Flow voids, and that explains the tenacious bleed if they go to surgery. They do have a lot of fragile vascular supply to the tumor. Dumbbell shaped sign, and again, because of the rapidly growing tumor, and it's for the same reason they are often present with supracellular extensions and cavernous sinus invasion مثل ما شفنا ويا كيساتنا. So treatment modalities, we don't prefer surgery. It's very complicated. It tends to be very complicated unless there is visual field loss or for diagnostic purposes. Well, diagnostic حقيقة من نسرع للsurgery. We should be able to make a diagnosis in the majority, not all the cases. لكن أغلب الكيسات ممكن نشخصها radiologically and by the history. And مرة أخرى if the patient has a history of cancer هذا يسهل علينا الأمور. ولكن إذا مثل ما الحالة شفناها الأولى، ولكن إذا ما كان عنده cancer then we have to look for one. It doesn't exclude. And the pituitary mets can be the first presentation. So as a practice point, any patient who come to my practice with pituitary or adrenal adenomas, I do ask routinely, consistently, هل عنده هذا المريض عنده cancer in the past or not, even if remote past, and nocturia. And please do remember the patient doesn't always have to have consistent nocturia. It can be intermittent and can have had it in the past, previous few months ago. So it can be the pituitary cancer can be the first presentation مثل ما شفنا بالحالة الأخيرة. المريض ما كان عندها breast cancer, but we found out later on that she does have breast cancer, and the pituitary lesion was the first presentation of metastasis. Okay, that's very important to understand. مو معناها ما عنده cancer, less likely to be. So it's very important to appreciate. And of course it can present many years after the primary resected مثل ما كان عندنا بالمريض الأول of renal cell. 17 years ago he underwent left nephrectomy, and 17 years later he developed the pituitary metastasis without cerebral involvement. DI can be ongoing on transient, unusual polyhormone deficiency, disproportionate to the tumor size. And ophthalmoplegia, of course. So pituitary mets are important cause of pituitary mass lesions, can be dedifferentiated, and there are second primary lesion, the pituitary, which can be very aggressive. Please do remember that the pituitary lesion can be difficult to differentiate from non-functioning macroadenoma. Can be very difficult to differentiate. So you have to be very careful. And of course, if you have a wide stalk يسهل عليك الأمر، وإذا كان المريض عنده history of cancer أيضا يسهل عليك التشخيص. But it's not always there to start with. مثل ما شفنا في الحالة الثانية الستوك كان normal بعدين صار thick after the So that was my last slide, and I hope you enjoyed this month Grand Round, which I took you through two important common encounters that we have to face in our pituitary world. It's a small gland with a lot of pathologies. I'll leave it as such, and I hope to see you all next month with another pituitary case discussion. Thank you all.